Pues si os parece, pasamos ya a la tercera presentación de Andrew Oxman, que se titula Estrategias para implementación de las guías de práctica clínica.
Of a sampling of resources to address implementation. And it comes from another European Union project that was called TICD, which stands for Tailored Implementation for Chronic Diseases. And we generated this list of resources as part of that project. I've made the list available to the organizers for people who would like the full list. I'm just going to give you some examples. So the first point here is there's a lot of jargon, and implementation is called different things by different people, and it's complex. Implementation is used by many people, quality improvement, knowledge translation. These are very much overlapping concepts. I would be very hard put to give you clear distinctions between how they're used by different people. And in fact, Anne McKibben and her colleagues at McMaster have identified over 90 different terms that are used to describe use of research. Similarly, there's a lot of frameworks, a lot of models, a lot of theories. On this page, you can see the first two are reviews of different models and that are used in implementation. And what you can see in both cases, after doing a review, the first one of 14 different models and the second one of 28 different models, the authors came up with respectively the 15th and the 29th model and have added one more. Similarly, as part of the TICD project, we looked specifically at checklists are methods for identifying what the key barriers and facilitators are for implementing a recommendation. We identified 12 checklists that met our inclusion criteria, and because none of there were inadequacies with all of these, we've developed a 13th, and I'll say a few words about that later. Other examples of how complex this area is, Trish Greenhow did a non-systematic review of a vast and complex literature from 13 different research areas and came up with a very complex model for diffusion of innovations or implementation. Taking a somewhat different approach, Michelle Vensing, who was the head of the TICD project, reviewed 29 theories that are used in implementation. They come from psychology, sociology, economics, education, and management. And out of these 29 theories, there were 30 factors. In other words, a lot of similarities. There's almost one theory per factor. So the number of factors really that are relevant turn out to be far fewer than the number of theories that are used to try to summarize these different factors that describe determinants of behavioral change. So what I'll do is just give you some examples of a range of different types of resources that are relevant to implementation, starting with some general resources that are very broad and cover the full range of resources, and then resources related to selecting which healthcare issues to improve, which is the first step, and then issues related to designing and evaluating interventions to improve those areas that you've determined warrant implementation efforts. So there's books, there's journals, and there's websites that provide general resources. The example here is a book written by Richard Grohl, who was in some ways the grandfather of implementation science, Michelle Wensing, who worked with Richard at Nijmegen University, and Martin Eccles, called Improving Patient Care. It's one of the better books to get a good overview of the science behind A somewhat different book from NICE, which has a very extensive implementation program compared to most guideline organizations. It's very practically based on practical experience, not rigorous evaluations, but it provides interesting reading about the efforts of a major guideline organization to try to ensure implementation of its recommendations. In terms of journals, Pablo mentioned Implementation Science, which I think has, over the past years, become a dominant journal in this area, but there are many others, quality assurance journals and other journals where literature gets published of research evaluating implementation strategies, as well as theories behind implementation and tools and resources for implementation. And there are several websites. This GiraNet is a website that includes a number of different resources, and another website developed by the grade group, the Gin McMaster Guideline Development Checklist, includes a very broad range of resources with links to these different resources, beginning with organization and budget and planning, training issues at a program level, and going through to updating recommendations. So not strictly restricted to implementation, but including implementation. So first step is stakeholder involvement. Most of you who work with guideline development or HTA have probably given some thought to this. It applies to several steps, starting with setting priorities for which guidelines to develop, to make sure that you are developing guidelines for important problems where implementation subsequently will be warranted. Stakeholder involvement in developing indicators that you use to measure whether or not people are in fact adhering to the recommendations. Priority setting, stakeholder involvement in quality improvement, deciding which areas require efforts to improve quality and how to go about doing that, and stakeholder involvement and evaluation. And the particular tool shown here is the IAP2 spectrum of public participation. And what's nice about this fairly simple, widely used framework is it describes from different levels of participation, ranging from simply informing stakeholders to empowering stakeholders to make decisions, what the public participation goal is, the goal for participation or stakeholder engagement at each of these levels, what's promise is being made when you say you want to do this to the public, and examples of different techniques for different levels of engagement or involvement. The next set of resources look at priority setting, and here again, priority setting applies right from the beginning. Which guidelines are you going to develop within a guideline? Which recommendations are going to be made? Once you've done that, setting priorities for indicators to measure whether or not people are adhering to the guidelines and deciding where efforts are warranted to improve adherence to the guidelines. And also setting priorities for evaluation of efforts to implement guidelines. So this is a nice framework for priority setting, comes from a systematic review of priority setting methods. It was developed around priority setting for research, but I think the basic issues are relevant to priority setting for a broad range of different priorities that need to be set in going from deciding which guidelines to develop to making decisions about implementation efforts. There's a huge number of resources for the guidelines themselves. So once you've decided a guideline is a priority, there's networks like GIN, like the network you have here in Spain of HTA agencies and guideline developers. There's databases like the GIN database or clinicalguidelines.gov in the US. There are a couple of, at least a couple of databases of guidelines in Spanish. and methods, including methods like we've described in the previous talks for developing guidelines. There's now a large literature providing guidance for methods to be used in going from evidence to recommendations. The next step is, once you figure out what you think people should do, is to measure whether or not they're in fact doing that. And so this involves developing indicators, identifying indicators where they exist, or developing new indicators where they're needed, and methods for measuring what people are doing. The example shown here is again from a systematic review of approaches to doing this, identifying indicators, developing indicators, and measuring whether or not people are in fact adhering to guidelines. I mentioned the TICD checklist. So what this is a list of barriers and facilitators that may be relevant to a particular recommendation. It's one of the tools that's incorporated in the evidence to decision framework. So for guideline panels where they consider it important, can go through considering in a systematic way potential barriers and facilitators as a starting point for determining what sorts of efforts are likely to be helpful or necessary to implement recommendations. When it comes to designing interventions, the first step is looking at evidence that already exists. There's now a large body of evidence that looks at the effectiveness of different implementation strategies, and there's methods for designing interventions. So what you're seeing here is a screenshot from a database called PDQ Evidence. If you do a Google search for PDQ Evidence, it will pop up. And this is a database of health systems evidence. It includes about 1,000 systematic reviews of implementation strategies, different types of implementation strategies, some reviews looking at implementation strategies for specific types of conditions, are looking at implementation in particular settings. The particular example that's shown here is from a Cochrane systematic review of tailored interventions to overcome identified barriers. So these are interventions where a group of people has used a systematic approach to identify what are the key barriers to implementing recommendation, facilitators for implementing that recommendation, and then explicitly design the intervention based on those barriers and facilitators to address those or take advantage of them. Recently, we did an overview of systematic reviews. This was commissioned by the Directorate for Health in Norway that's responsible for guideline development in Norway, who's become increasingly, in part because of demands from the Auditor General, concerned about ensuring implementation of the guidelines that they're responsible for developing. So we did a systematic review, or an overview of systematic reviews, where we selected 19 systematic reviews. And we were able to conclude that implementation interventions such as electronic decision support, educational meetings, outreach visits, audit and feedback, tailored interventions are probably effective. There's moderate quality evidence that these interventions work most of the time. But the size of the effect varies. It's not consistent across studies. It's difficult for many of these to explain that variation, although for some there are good explanations. And the effect on clinical practice most often is moderate. Changing clinician behavior, it turns out, isn't any easier than changing other types of behavior. It's difficult to change people's behavior. And so the effects of these interventions are rarely dramatic, most often they're moderate. And consequently, the expected effect on health outcomes is modest, given that you're asking people to implement clinical interventions which benefit only a proportion of the patients who receive them, so the end effect on clinical outcomes is going to be the combination of to what extent you're able to change behaviors of clinicians, sometimes patients, combined with how effective those interventions are. For other interventions, the size of the effect varies considerably across studies, and it's difficult to explain the variation. Consequently, the effectiveness of those interventions is uncertain. And for some, such as financial incentives and public release of performance data, evidence is lacking or scarce, so we really don't know what the effects of those interventions are. So summarizing, these are the interventions for which we found moderate certainty of the evidence that these interventions are effective: clinical decision support systems, including reminders, educational outreach visits, including what's sometimes called practice facilitation, audit and feedback, use of local opinion leaders, tailored interventions, and educational meetings have all been shown with moderate certainty of the evidence to effectively change clinicians' practice and improve adherence to recommendations. And these are interventions for which it's uncertain because of very low certainty of the evidence what the effects are. It includes internet-based learning, interprofessional education, printed educational materials, economic incentives, interprofessional collaboration, checklists, strategies to change organizational culture, and public release of performance data. The problem with a lot of those reviews is that they tend to focus on ways of delivering an intervention less than what the active ingredients are. So if you think of something like educational meetings can include a broad range of behavioral change strategies. It may focus on knowledge, may focus on attitudes, it may focus on skills, and so the content of educational meetings can vary quite a bit. And so the challenge is to identify what are the active ingredients and how do we begin to think about those as opposed to the ways that we deliver the active ingredients. And probably the most advanced approach to doing that is what's called the behavioral change wheel that Susan Michie and her colleagues have developed. It's still very early days, and it's still a fairly limited approach to doing this, but I think it's going in the right direction. It's not there yet. In terms of evaluating interventions, given that we're expecting most of the time at best moderate effects, we should be evaluating our efforts to our implementation efforts when we first decide to invest resources in trying to improve implementation of recommendations. And the resource shown here is from an earlier European Union funded project that we had called Rebecca. And North Star is a tool for designing evaluations of implementation strategies, and it includes detailed guidance for designing both randomized evaluations of implementation strategies and non-randomized approaches to evaluating implementation interventions. Lastly, and I think most importantly, and what's really major challenge in most countries is developing quality improvement programs. So doing on a large scale something like what NICE is trying to do, to develop programs for implementation that are not one-off efforts, but are consistent, well-funding, well-designed programs to try to improve the extent to which evidence-based recommendations are adhered to and implemented in practice. And so this resource is an example of a nice summary of some of the issues that need to be thought through. It's from the Department of Health in the US. And it's just a useful map for thinking through what needs to go into an implementation program. And then there's some examples, but not a lot of examples of national efforts to do this. So this is another example from the UK, where the National Health System in the UK is funded what they call academic health science networks, with the aim of improving patient and population health outcomes by what they call translating research into practice or implementing recommendations in the national health system in the UK. So they've now got a complex set of group of both regional organizations and organizations that have different foci in terms of the content. And again, it's still early days, but it's an example of a substantial national effort to try to address this problem, of which there's very few, so we need to learn what we can from the examples that are out there. That was all I was going to say, so hopefully there's some time for discussion.
Muchísimas gracias, Andrew.